Okay, so as I kind of alluded to in the very beginning, there's a difference between treating neuropathic pain and nociceptive pain. So neuropathic pain, again, is pain caused by malfunction in the nervous system at any level. And here's an incomplete list of examples of neuropathic pain problems. Postherpetic neuralgia, CRPS, or complex regional pain syndrome, also known as reflex sympathetic dystrophy. Elements of cancer pain, phantom limb pain, neuroma, trigeminal neuralgia, entrapment neuropathies, peripheral neuropathies, such as you might see with diabetes or alcoholism, and myelopathies like you might see post-traumatically or with HIV. The pharmacotherapy for neuropathic pain is basically trying to find medicines that alter nerve function. And the main tools we have to do that are antidepressants, of which there's two main categories. The tricyclics is the older, well-established, lots of evidence group, and the newer SNRIs, selective norepinephrine serotonin reuptake inhibitors. And there's pretty good evidence for those too. So that's one category, antidepressants. The other category is the anti-epileptic or anticonvulsant drugs, of which gabapentin and pregabalin are probably the most used, but others can be used also. And then there's roles for other drugs such as sympatholytics. There's a question, do opioids have a role in neuropathic pain? Anesthetics and steroids. So first question for you in this category. Which of the following are mechanisms of action for neuropathic pain meds? And for each letter, there are two components, both have to be true. A, they enhance spinal norepinephrine and serotonin, and they block cytoplasma mRNA. B, they stabilize neuronal membranes, and they enhance spinal norepinephrine and serotonin. C, they bind and modulate neuronal calcium channels, and they produce chloride channel inhibition of neuronal mitochondria. D, they have chloride channel inhibition of neuronal mitochondria, and they bind or modulate neuronal calcium channels. E, they bind and modulate neuronal calcium channels, and they block cytoplasma mRNA. So the answer is that they stabilize neuronal membranes, and they enhance spinal norepinephrine and serotonin, which, as I mentioned before, are inhibitory of pain in the spinal cord. So stabilizing neuronal membranes, enhancing spinal norepinephrine and serotonin, and binding or modulating neuronal calcium channels are the known mechanisms. All the other things that I put there were red herrings. So the common neuropathic meds, gabapentin, pregabalin, and duloxetine. And I give here some standard dosing schedules and target doses for these medicines. Anticonvulsants, so not so commonly is Tegretol or carbamazepine. It has some things to mention about it is that there are dangerous dermatologic reactions, desquamating rashes associated with a particular gene, which is found almost exclusively in Asian populations. So many neurologists will not use this drug with an Asian patient. You need to monitor CBC, reticulocytes, liver functions, a whole bunch of stuff when you're using carbamazepine. You should recognize it is inducer of many of the cytochrome P450 enzymes. Phenytoin or dilantin can be used, again, not commonly used anymore. You do have to monitor drug levels, CBC levels, liver functions. You have to do dental exams. It seems to modulate the sodium and the calcium channels. Gabapentin is extensively used in the pain world. It seems to block voltage-dependent calcium channels and may modulate the release of excitatory neurotransmitters. All anti-convulsant or epileptic drugs, you need to watch for mental status changes. Gabatril, relatively rarely used. Oxcarbamazepine is a metabolite of carbamazepine, marketed under the name Trileptal. It is used much more commonly because it requires much less monitoring, and I think its association with this dermatologic reaction is very rare. And zonisamide or zonogran is occasionally used in the pain world. It does require some monitoring of lights and CBC. I should mention Trileptal can drop sodium levels. Difference of opinion, I've talked to several neurologists. Some routinely will check sodium levels after being on Trileptal for 30 to 60 days. Others do not check it unless there is symptoms that make them concerned. Lamotrigine or lamictal is another one that is used in the pain world occasionally. It too has had dangerous dermatologic reactions associated with it, can affect eye function, needs eye exams, and again affects sodium channels and neurotransmitter release. Topamax or topiramate is also used. It has got some popularity because it is the only anti-epileptic and to some extent the only anti-neuropathic medicine that's associated with weight loss. Most anti-epileptics are associated with weight gain. Antidepressants vary from weight gain to weight neutral. Again, pretty much the only one associated with weight loss is topiramate. If a patient has a history of kidney stones, it should not be given because it can cause kidney stones, again, particularly in patients with that history. Mechanism of action is similar to the others. Pregabalin or Lyrica is now becoming very popular in management of neuropathic pain. It binds to calcium channels, causing a reduction of release of neurotransmitters, excitatory neurotransmitters. It does not really require lab monitoring. But like all the others, you do have to monitor mental status changes. Keppra and Felbitol are others that are not commonly used. Felbitol has special risks of aplastic anemia and hepatic failure. I've never seen it used in the pain world. So pregabalin binds to the alpha-2 receptor, particularly the delta subunit, and this seems to modulate the calcium influx. When you reduce calcium influx, you reduce neurotransmitter release. If you were to block that binding, then you are blocking the effect of pregabalin, so it seems to be related to its impact, but exactly how all of this translates into pain relief in humans is not really clear. So pregabalin is analgesic, anticonvulsant, anxiolytic. It's a sleep modulating agent where it increases slow wave sleep. It's indicated for postherpetic neuralgia, for diabetic neuropathy, for myelopathic pain, and for fibromyalgia, meaning FDA labeled for those purposes. Fibromyalgia, an annoying source of chronic pain that afflicts middle-aged women, can now be cured with a brand new drug. She responds, call me when they have a cure for the other source of chronic pain that afflicts middle-aged women, middle-aged men. Question, for neuropathic pain, studies support the use of, and again, all parts of each choice have to be true, A, gabapentin, amitriptyline, lorazepam, and haloperidol. B, pregabalin, amitriptyline, fluoxetine, and venlafaxine. C, fluoxetine, duloxetine, gabapentin, and droperidol. D, duloxetine, gabapentin, pregabalin, and imipramine. Answer is D. So benzodiazepines, neuroleptics, SSRIs as opposed to SNRIs, SSRIs, these have no evidence for an analgesic effect. TCAs, SNRIs, and anticonvulsants do have evidence for analgesia with neuropathic pain. For antidepressant drugs, especially this is true for tricyclics, the analgesic dose appears to be less than the antidepressant dose. They improve sleep, improve mood. They are particularly useful for neuropathic pain and for headaches. They have serotonergic and noradrenergic effects, at least the ones that are effective do. They seem to block sodium channels, block NMDA receptors, block histamine 1 receptors, alpha receptors, serotonin reuptake, muscarinic and nicotinic acetylcholine receptors, and they may induce endogenous opioid release. So lots and lots of neurochemistry going on here. So Cymbalta, this comes from a study looking at it with diabetic peripheral neuropathy. Like we think other antidepressants, works via centrally mediated inhibition by increasing the activities of the descending inhibitory pathways, which are releasing serotonin and norepi. Again, key point, serotonin and norepi are inhibitory of pain in the spinal cord. This is all basically saying this. Okay, so evidence-based use of psychotropic medications does exist for tricyclics, for SNRIs, of which there's primarily Cymbalta, and which is duloxetine, and venlafaxine, marketed under the name Effexor. Anticonvulsants, NMDA receptors, beta blockers, and cannabinoids, all of these psychotropic medications, there is some evidence. Anxiolytics, antipsychotics, and SSRIs do not appear to have direct analgesic effects. Let's take a quick look at need to treat numbers. So for tricyclics, the need to treat number for neuropathic pain is 3.6, and for venlafaxine, 3.1. These are good numbers. Okay, that means you're going to get pretty good pain relief in at least one patient when you treat 3.1 or 3.6 patients. Even better numbers when you look at diabetic neuropathy, 1.3, postherpetic neuralgia, 2.7. It should be noted that for HIV neuropathies, tricyclics do not appear to be effective. What about the number needed to harm? So that's sort of the opposite of number needed to treat. So for a major adverse effect leading to withdrawal from use of the drug in the study was 28. So you want a high number here as opposed to a low number for need to treat. 28 for amitriptyline, 16.2 for venlafaxine. I was surprised by this. Generally, we think of venlafaxine as being better tolerated than amitriptyline. For minor effects, 6 for amitriptyline and almost 10 for venlafaxine. In patients with cancer-related neuropathic pain, if you look at studies that add either gabapentin or imipramine to opioids, it didn't make a difference which one you added. So gabapentin plus imipramine plus opioids, if you use all 3 of those, you have a greater effect than just adding one of those to opioids. In patients with spinal cord injury and depression, amitriptyline was greater than gabapentin. There's a general thought that if a patient is evidencing depression with their pain, then you're going to get a better effect by using an antidepressant. In patients with central post-stroke pain, there doesn't seem to be any difference between amitriptyline and carbamazepine. I don't remember the numbers, but probably neither work all that well because it's very hard to treat central post-stroke pain. No significant difference between gabapentin and pregabalin and lamotrigine when compared with tricyclics. These are small studies. And there is a small short-term study looking at lidocaine patches, comparing it to oral pregabalin or Lyrica. And again, this is for postherpetic neuralgia and for diabetic neuropathy, and finding them equal. Again, in these same 2 conditions, if you sort of put studies together and indirectly try to compare, we find that duloxetine, Lyrica, gabapentin work better than lamotrigine and lacosamide. Pregabalin seems to work better than topiramate, which is Topamax. Differences were not found when we did these other comparisons. In the case of spinal cord injury and the neuropathic pain that can follow, we find that gabapentin and pregabalin are effective. Lamotrigine, interestingly enough, is only effective in those with an incomplete spinal cord injury. Valproate was not effective. Amitriptyline was only effective in those patients who were also depressed. And Keppra was not effective. Okay, we are going to shift to talk about the class of NMDA receptor antagonists. This area is rapidly growing of importance because we're in an era now where everybody's looking for alternatives to opioids. And NMDA receptors is one of our main tools. So what are they? They are ketamine, memantine or Namenda, amantadine, methadone, and dextromethorphan. Those are the available NMDA receptor antagonists. So a question for you. In order for the ion channel component of an NMDA receptor, maybe I'll just help again. This is an NMDA receptor complex. In the middle is a calcium ion channel. So in order for that component to open, which of the following must occur? So in its resting state, it's closed. In order for it to open so calcium channels get through, what must occur? A, ketamine must bind to the receptor and the calcium plug must be kicked out. B, glutamate must bind to the receptor and the magnesium plug must be kicked out. C, glutamate must bind to the receptor and magnesium must also bind to the receptor. D, endorphins must bind to the receptor and the magnesium plug must be kicked out. So the answer is glutamate must bind to the receptor and the magnesium plug must be kicked out. So magnesium doesn't bind to the receptor itself, rather it plugs the ion channel. Ketamine blocks the receptor, it does not open it, and there is no such thing as a calcium plug. Endorphins are not involved in this process, at least not directly. Another question for you. Activation and upregulation of the NMDA receptor contributes to which of the following responses? A, increased neuronal sensitivity and decreased response to opioids. B, decreased neuronal sensitivity and increased response to opioids, the opposite of A. C, both are decreased neuronal sensitivity and response to opioids. D, both are increased neuronal sensitivity and response to opioids. E, increased analgesia. So the answer is that activation of the NMDA receptor leads to increased neuronal sensitivity and decreased response to opioids, also known as tolerance. Okay, let's go through these drugs a little bit. Ketamine, a synthetic drug first synthesized in 1962, FDA approved in 1970, used in Vietnam in the Vietnam War as a field anesthetic, became a recreational drug in the 70s and subsequent. It is only commercially available in IV form, but it can be compounded by compounding pharmacies into a topical gel or into an oral capsule. And I give typical doses here at the bottom. Ketamine can be used post-op in low doses to reduce opioid risk, decrease nausea and vomiting. In chronic neuropathic pain, it is being used topically, orally, IV, especially for the treatment of complex regional pain syndrome. And there's more and more evidence that it has antidepressant effects. The IV doses for the treatment of depression are significantly lower than the treatment of neuropathic pain. Side effects are really prominent cognitive side effects, cognitive impairment, hallucinations, schizophrenia-like perceptual changes. These are temporary, and they wear off rapidly after the stopping of the ketamine. Abnormal heart rhythms and rate, particularly tachyarrhythmias. The risk of increased intracranial pressure. They can cause anorexia, nausea, increased salivation and vomiting. Typically in higher doses, lower doses may actually help with nausea and vomiting. Increased skeletal muscle tone, you may get tonic-clonic movements. Double vision, increased ocular pressure, so glaucoma is a relative contraindication, and nystagmus. What about ketamine IV therapy or infusion therapy? So typically the doses, once the patient has been worked up to it, are 200 to 400 milligrams over 4 hours. Higher doses can be used, and outside of the United States, coma therapy is used. It is primarily used for treating CRPS, but it can be used for other neuropathic conditions, including headache. It requires an infusion center with some kind of monitoring, lots of associated mental status changes, logistically difficult for patients because of the frequency and the extensive time of the infusions, and they can't drive afterwards. We don't let our patients drive for 2 days after a ketamine infusion. May also be useful for the treatment of depression and PTSD. Okay, question for you. Which of the following conditions has the best evidence for the use of magnesium? A, CRPS. B, migraines with aura. C, trigeminal neuralgia. D, migraines without aura. E, renal failure-induced headaches. The answer is migraines with aura. Magnesium can be helpful for a variety of pain conditions, but the best evidence is with migraines with aura. So it can be used orally. Doses are 400 to 900 milligrams a day. If the patient is getting too much, they get diarrhea. IV boluses of 1 to 2 grams or 30 to 50 milligrams per kilo can be used. Side effects, diarrhea. Multiple dosing can lead to bone thinning. Magnesium oxide in doses up to 400 milligrams is pregnancy safe. One of the very few things that we know is pregnancy safe. Oral magnesium is, in general, lacking evidence for efficacy, dangerous in patients with kidney failure. The strongest evidence for magnesium is for migraine with aura, or for migraines that are menstrually related, or for migraines that may be associated with magnesium deficiency. There is a thought in the neurology world that there is a group of patients like this that may have genetic inability to absorb magnesium, or may have magnesium wasting, or increased magnesium excretion, or just poor intake. There's some evidence that it can be useful for post-op pain, and there is some evidence that it may potentiate the effects of IV ketamine when treating CRPS. Okay, we are